All right, guys, I'm going to start with analgesias since that's the first one that I have up in front of my face. All right, so for the analgesia, again, that means pain medicine or that we're going to be addressing your patient's pain. Again, it is whatever the patient says that it is. The definition between threshold and tolerance, again, threshold is that stimulus that is needed to produce that, hey, there's pain going on. It's a physiological response versus tolerance is that amount of pain a person can handle while still being able to function and do everything. And that's more of a psychological response. And that that tolerance, again, can be fueled by a patient's society, environment, culture. You should know, again, the difference between acute and chronic. Acute is self-limiting, sudden onset, usually does reside once it's treated. Chronic, textbook says 3 to 6, but it definitely can occur longer than that. It can be lifetime or years. Again, some of those components difficult to treat, that threshold tolerance and physical dependence that can come under that chronic pain management. Few of the different pain types that nociceptive. So again, it's that direct stimulus to a pain receptor. We have pain receptors on our skin. So again, if I touched a hot stove, I cut myself, that's that nociceptive. It's those pain receptors pick up that insult and it's sent right to the brain. Somatic is kind of more visceral or deep internal, whether it's skeletal, muscle, or joint. So thinking about those sprained ankles, knee injury, usually that arthritis kind of pain. The referred pain is pain that's going to happen in a different spot other than what really is going on. So my examples was appendicitis and gallbladder attacks. Neuropathic is that nerve pain, and you'll see a lot in your diabetics. And then phantom pain is in someone who's had an amputation and that brain is still recognizing that that limb is there. You can do pharmacological or non-pharmacological measures with managing your patient's pain, and pharmacological does not always necessarily mean it will be opioids. It can be anti-inflammatory medications like your NSAIDs. It may be something as simple as an acetaminophen, and then just the different things for non-pharmacological. You can take a look. PCA pumps, again, are generally for patients to control their own dose of medication, those pumps. And multimodal pain management is usually that synergistic effects where you are looking for that two things put together will provide better benefits than one thing alone. Okay, adjuvant drugs, the example was like your Tylenol 3s, your Tylenol 4s, where you'll have more than one medication that's going to be combined into one pill, like Norcos or Lortabs. And then in general, what an opioid is, it does bind to the body's those receptors that we have in the body, and it helps to produce that euphoria. You absolutely have to go back and look at agonist versus agonist-antagonist, and then just an antagonist alone. So agonist, I want to create an action. I want to produce on purpose that what I'm looking for to treat in that patient. So again, no matter if it's pain medicine, if it's for, I said, heart or whatever, where that antagonist, if you think of it like an antidote, because now I need to go in there and do the absolute opposite. I need to get off of that. I need to bump those agonist medicine off those receptors. I need my antidote to bind to those receptors to reverse the effects that it's having. And then the combo agonist-antagonist, like I said, is kind of a combination of the two. Go back over and look at where when it comes to the agonist, so your pain medicines, what is considered mild, what is considered strong. And when there's some general indications for an opioid, so that moderate to severe pain, if it's something that was mild, they may benefit more from an NSAID or acetaminophen or something. We know that the opioids can be also used for other conditions, so like coughing, treatment of diarrhea. The ceiling effect, again, meant just an increased dose of that medication won't increase the response that that patient has to it. It's kind of like they're tapped out at, it's just not going to help even if I increase the strength of it. And that's more with your codeine. The codeine, looking again, it will produce that analgesia effect. It's just more for a mild to moderate, and it's not as, like I said, up there as far as the efficacy, or if somebody was having severe pain, and it's not going to control like that severe pain. Looking at the fentanyl, we talked, there's many different routes of it, but the biggest thing was that transdermal. It is only good for, every patch is every 72 hours. And then also it's not for acute breakthrough pain. It's not for acute pain because it does take 12 to 24 hours before it will kick in and provide pain relief for that patient. So if somebody's really having acute pain or breakthrough pain, then you are looking at an immediate released form of an opioid, something like the oxycodone or something, and that will help bridge them until that fentanyl can really kind of kick in. We just talked about Dilaudid, and it's just a very potent analgesic, and that's a lot stronger than even morphine is. With the morphine, we know that it can be naturally occurring from that opioid poppy. Severe pain, it is used to control. There's a high abuse potential for it. There are different routes of administration for it. And the big thing too was just, again, remembering that twofold. For your morphine, I am definitely looking at their respiratory, their blood pressure, but again, assessing that patient to see what kind of medication they truly need, because I don't want to pull out the big guns if it's a kind of a mild to moderate and can be treated with something else. We talked about methadone, and methadone is the drug of choice for someone who has an addiction or that detoxification purpose from opioids. It has a very long half-life. Patients only have to take one dose every day or every 24 hours. And it does accumulate within the liver, the kidneys, the brain. We did say that it will go in and potentially still treat the pain, but not give that euphoric feeling, which a lot of the addiction people have that craving for. We know that different factors will guide the healthcare provider in ordering which medication would be best. Equinalgesia, again, it's just that concept is when you are transitioning patients from different routes or maybe in between different medications that, again, you know what, maybe you were getting the Dilaudid through the IV, now we're going to switch over to the oral. It's not going to be dosed at the same milligram strength because the routes will have different strengths, but we're still going to give you enough to provide that comfort, so that kind of equal playing field. Adverse effects with the opioid analgesics. It talked about the CNS depression, the GI, the urinary retention, constipation, low blood pressure. So go back over that. And we talked about ways to prevent constipation when you're doing your patient education. So fiber, fluids, movement if possible, over-the-counter stool softeners. We know that there are some situations that opioids would be contraindicated. So that's allergies, asthma, and then just using extreme cautions in patients that already have a respiratory insufficiency, obesity, sleep apnea, that perilytic ileus. Or when you think of those head injuries with that pressure that's going to build up inside that head and so forth. Okay. Just being very cautious when you're using opioids with any other kind of medications, and also caution with alcohol use. We talked about what is tolerance, dependence, and addiction. And again, tolerance is that you get used to a certain strength of a medication, and your body gets to where it's not going to be feeling pain relief from that strength, so you're going to have to go up to a different dose and up, and your body just continues to get tolerant to those different steps of strengths. Where dependence is more of the body is looking for that medication, and the body can go through withdrawals if that medication has been used for a long time, and if that medication is abruptly stopped, the body does know, and the body will go through withdrawals. And that's some more of your physiological versus your psychological, which is truly the addiction, when that patient is psychologically kind of drug seeking, if you will, and looking at taking that medication for other reasons than its intended purpose. We talked about overdose and withdrawal, so Narcan, we know Narcan can be given rapidly. It potentially can cause withdrawal symptoms in chronic users because, again, you are reversing the effects of that opioid, and it has a very short half-life, it has a very quick onset, and you can repeat a dose if needed. So we're always going back to, again, looking for that nursing assessment prior to giving your opioids. What is their respiratory status? What is their blood pressure status? Knowing that, also being very familiar with Narcan, when you would administer the Narcan, when is it appropriate? My apologies. I would just eyeball, there are a lot of different withdrawal manifestations we talked about. When you're looking at non-opioid or miscellaneous kind of drug therapy, the tramadol is a miscellaneous analgesic. It not so much an I want to say opioid. It has a weak opioid receptor activity though, but we still do not use that if that person has a history of narcotic abuse. It's good for moderate pain. Okay. With lidocaine, we talked about lidocaine being transdermals, and that the biggest thing, this is available over the counter or with a prescription, and again, it cannot be used more than 12 hours per day, up to 3 patches on an area, but no longer than 12 hours a day. Then it needs to be off for a complete 12 hours, then you can reapply it, and just keeping the eye on the skin. Talking to your patients about any kind of herbal products whatsoever, whether they are, like I said, the flower derivatives or St. John's worts or oral pills that they buy over the counter. Same thing for essential oils. If your hospital does have a policy on them, they need to be 100% oil. That analgesic pain assessment, so again, pain's at 5th vital sign, you absolutely have to assess. You can't just go and give it to them. So you're wanting to go, the onset location, think of your old carts, and trying to make sure that you see if the patient if it's time for them to have their pain medication. Always need to look and see when was the last dose, because you don't want to make a med error by giving it too close. And then you're going to document that you gave it, and then you're going to go back in and you're reassessing. Okay, and again, it just depends on that route. If it's oral, I wouldn't assess probably sooner than 30 minutes because it can take anywhere from 30 to 60. If it's IV push, it can be within minutes. So it's just, that kind of guides your reassessment. We're always looking at other information as far as with medications was there allergies? Is there, again, that's lifestyle use as far as alcohol or illicit drugs, any other contraindications. Keep an eye on those blood work results as far as kidney, so BU and creatinine and GFR, liver function, the ALT and the AST, if the CBC needs to be looked at. Okay. Keeping in mind some important nursing diagnoses, again, when you're using these analgesics, would be risk for injury or risk for safety. And then some of those other ones with the impaired gas exchange, it can be an elimination pattern because of potential for constipation. And then with the implementation portion, so again, everybody's individualized, so not every 2 people will be the same when you're assessing or in the pain management delivery as far as how they tolerate it. And so mild pain management, again, is usually going to be with something like acetaminophen, tramadol, or NSAIDs. And then moderate to severe pain comes into more that multimodal method where you're using two is better than one. Sorry guys, I'm trying to talk over their barking. With that nursing implementation, again, we want to administer those analgesics before the pain gets out of control. Also, if there's any pharmacological measures that can be used, we try to use those. As far as evaluation, we want to see if the medication was effective. We redo that pain scale, so hopefully to see if it was at 8, 9, 10, that we've been able to get it reduced to, even if it's like a 3 or 4. And again, you may not always get every bit of the pain gone, but a reduce in it is a great goal. Monitoring for any hepatic toxicity and any side effects with any of the medication use. And then keeping in mind, again, for safety measures, keeping side rails up, bed alarms if needed, contacting the healthcare provider if there's a decline in the patient's condition or abnormality with the vital signs, and then especially if that respiratory rate is less than 10 to 12 breaths per minute. Okay. And just an overcap again, that with pain is subjective. We're never assuming anything. That before and after assessment. And keeping in mind that analgesics are helpful for acute or chronic, and you really do have to see what is that level of pain for that patient. And remember, if it's mild to moderate, it's going to guide me to do this. Whether it's severe, then it would guide me to use this medication.
Sorry, I couldn't hear what you said.
Okay, we're going to move on to anti-inflammatories and all of that. So looking again just at general knowledge of what is that inflammatory process. So we said it can be friend or it can be foe. What is the signs of the inflammatory response? Redness, swelling, warmth, fever, pain. When do we get concerned if it's going outside of that? Again, if somebody had surgery and we were still seeing it not resolving maybe up after 48 hours, or it's getting worse with anybody, and we know that then that could potentially be an infection. Some of the inflammatory response, though, can certainly come from chronic conditions. So when we talk about arthritis or Crohn's, or we talk about back injuries and things like that. Well, how do anti-inflammatories work? So they just go in there and they block or they alter those chemical reactions that are going on in that cellular level that's going to reproduce or produce those inflammatory manifestations that we see and that we know that goes on. Okay. Some of the medications that you will see under this category will be your corticosteroids, your NSAIDs, your antihistamines, anti-gout, anti-arthritis. I'm not sure if we talked about immune modulating agents. We'll talk about that more in 119, but immune modulating agents are more effects on inflammation and chronic disorders that are like with your Crohn's, or a lot of times they'll be used for folks that have HIV or other cancer-related diagnoses. All right. NSAIDs, so they're very good for mild to moderate. They're good for musculoskeletal, post-operative, headaches, anything like sprained ankles, anything that can be really relatively common in injuries or insults in the body that's going to produce an inflammatory response. Antipyretic is again meaning a fever reducer, and we talk about aspirin as that aspirin is an NSAID, but it isn't a platelet inhibitor or inhibition. It reduces the risk of clotting or thrombosis, and it is the only NSAID that can be used as a platelet inhibitor. When you're doing medications, they need to be given as ordered. You can't give a medication for pain if the order says it's for fever. Okay. We know that a lot of the NSAIDs, most are available over the counter, like the more mild, not strong doses, so like the 200 milligrams is what's common in your ibuprofen over the counter. in order to get a stronger dose, you'd have to have the healthcare provider write a script for like 4, 6, or 800 milligrams. We know that there are potential side effects even with the NSAIDs, so we're always still looking for those contraindications. There's just several categories of NSAIDs. So I think someone had asked me what was the difference between the aspirin and the NSAID. So really it's like you have the blanket umbrella of NSAIDs, non-steroidal anti-inflammatories. So that's just the category, and then you have different medications that will fall under NSAIDs, and it comes from their chemical makeup. So that aspirin is an NSAID, but it's not it's not grouped with the ibuprofen, it's not grouped with the Mobic, it's not grouped here. It's kind of its own entity of the salicylates, okay? So when you're looking at those chemical categories, again, we don't ask you of like, which one is this oxycam derivative? No, it's just that salicylates is its own chemical category, but it is an NSAID. Your ibuprofens, that chemical category is propionic acid. So I hope that helps a little bit. Okay. So aspirin, again, go back over that. It can be multifold with fever to reduce in pain, anti-inflammatory, and then that platelet inhibitor. A lot of times we'll see either 81 milligrams for low dose, sometimes the 325. It can take longer to work if it's enteric coated. What some of the kind of more blaring contraindications is we don't give it into teens or children because of the Rice syndrome. It can be hard on the GI system and cause nausea or dyspepsia or heartburn. With aspirin, we know that patients can get toxic on aspirin, and so some of the bigger ones that you may see with toxicity is the ringing in the ears. They're at higher risk for GI bleeding. Okay. So what we're thinking about is really those folks that, like I said, a lot of these medications are not just like a 1 or 2 times use. Folks that are really kind of chronically using these medications for the most part are the ones that could have these potential problems. Okay. We know that there can be interactions with people take aspirin with other medications. With the other type of NSAIDs, we're looking at apologize, I can't find my note here. Okay, so with one of them was, this is under the acetic acid. So this was your Toradol, your Indocin, and this is good for that moderate to severe pain with Toradol, but this is the one that usually you'll only see providers order it for 3 days at a time, and not more than 5. Okay. And also with Indocin, a big thing with Indocin is that GI upset. It is for pain. I do see it also for gout as well. Okay. The COX-2 inhibitor, the only one that is available is Celebrex, and it's really good for arthritis. We talked about like Mobic, Relafin. Those are just, again, other types of NSAIDs. Now your actual ones, those propionic acid, which is your ibuprofen, is good for mild to moderate. In some of the instances you might see those, again, is something like musculoskeletal, menstrual cramps, dental pain, gout. Can be used to reduce fevers as well. With NSAIDs, some adverse reactions that you're looking for, again, GI is that big one. We do encourage people to have some food or a little bit on their stomach to help decrease that upset, that nausea. Some of the things that, again, it can really be cause is that dyspepsia or heartburn. They're at higher risk for GI bleeding. We're looking at any hematological concerns at risk of bleeding, bleeding disorders. Okay. One of the medications that is very common is that cytotec or misoprostol, which will help to kind of counteract the effects that the NSAIDs can have on the GI system by kind of like protecting the barrier of the stomach and just trying to decrease the potential for that gastric erosion. Some of the NSAIDs contraindications, again, we talked about liver disease and kidney disease, bleeding disorders, so GI disorders or history of ulcers or current ulcer, that would be contraindicated. We said that some medications can increase somebody's blood sugar even if they're not a diabetic. So beginning NSAID therapy, we're looking at any reason why a patient would not be warranted to use it. So going back again to what is there any kind of bleeding disorders, clotting disorders, those kidneys, that liver disorder, anything like that. We're looking at all of those labs that we know is very indicated for NSAIDs because they can be hard on the kidneys, it can be hard on the liver. So that BUN creatinine, that AST, ALT, looking at that CBC for the components of any kind of bleeding disorder. So I'm really with a focus on the hemoglobin, hematocrit platelets, okay? Looking at cardiac responses as well, with like the troponin and the BNP. We talked about also one of the things with aspirin was that aspirin triad of symptoms. So people who have allergy, nasal polyps, and rhinitis, that's like they have all three of those, and those are folks that should not be using the aspirin. Okay. And just we always go back and tell patients if they have any issues with the medication. So again, if they're having any unusual color in their stool, any dark urine or bleeding gums, pain, anything, they should contact their healthcare provider. With enteric coats, we say again, it's enteric coated is for a reason. We want it where it's going to release that in the GI system, and it just helps to kind of cut down on sometimes that GI distress and so forth. So if it is an enteric coated medicine, they do not crush that or chew it. It needs to be swallowed whole. We touched a little bit about acetaminophen, that it is great for pyretic, so fever. It can be good for mild to moderate pain depending on what you're taking it for. However, it does not have anti-inflammatory effects. The action of acetaminophen kind of mimics aspirin, except no anti-inflammatory effects, okay? So patients that aspirin's contraindicated in, then they could probably use the acetaminophen. The recommended dose, again, is 4 grams or 4,000 milligrams. For adults in liver disease or alcohol abuse, it is cut in half, so 2 grams or 2,000 milligrams. And remember, there's a typo on that slide 40. So 2 grams is really 2,000 milligrams. Okay. And that's why we cut that cap off is, again, it's going to be metabolized through the liver, and the liver can just build up with too much if it's overdone. So other things that I'm screening my patient for before using acetaminophen is the drug allergies, again, any kind of underlying liver disease pathology, or if they have an alcoholism history. Okay. When looking at acetaminophen, and just again, we mentioned how the caution with overdosing on stuff, because your acetaminophen, yes, it can be found in like Norco, but it can be found So, I mean, that's prescription, but again, it can be found in a lot of the over-the-counter products that people are taking for different uses, not just buying it just for pain. So those cough medications, Mucinex, I talked about NyQuil, some topicals, they have acetaminophen in it, and folks do not realize that they may be doing double dosing on that product. Okay. We just talked about if there was acetaminophen toxicity, how would you manage that? And the antidote for that one was the Mucomist or the acetylcysteine regimen. We said Mucomist can be very, very harsh smelling, and so sometimes you can get it flavored so that it will be more tolerable in ingesting it for that antidote to reverse the toxicity. Reviewing the gout. Gout is an inflammatory condition because it is a form of arthritis that will build up in the joints, and like I said, especially the great toe, it will be very can manifest very suddenly, like overnight. It's more prominent in men. It can go back from genetics to dietary, and basically what happens is that the uric acid does not clear from the body, and so it will build up, and this uric acid will settle in the joint. And so just generally what it looks like, swelling, painful, but there is some specific treatment. So we talked about allopurinol or colchicine, which can be used for gout, and what the allopurinol is going to do is prevents the uric acid production. So like I said, if we can kind of limit that uric acid production, that's going to help the body time to kind of compensate, and if eventually it stops producing that uric acid, then we can treat that gout. With the colchicine, it will help to reduce the inflammation that's being caused by those uric acid crystals. Okay. With these crystals, if you Google it and kind of look at pictures, they almost look like sharp little pieces of glass that settles within that joint tissue, and that's why it's just so painful. They're very jagged looking. We know that if a patient is being treated for gout, my anticipation is that when they're having this flare-up, the uric acid level is probably elevated. But then when they start the medication, if I'm continuing to monitor uric acid, I should see it reduce. Okay, so that would be a therapeutic effect. And as always, I'm looking at several things with the gout medication, and not only the uric acid level, but hepatic functions, kidney functions, hematologic functioning. We said that one of the other things that could happen in a person was that Stevens-Johnson syndrome. So that was a picture of those like lesions, and that it can be actually fatal if it's severe enough, and a lot of folks will end up in an ICU setting for treatment of that. All right, that was it. Have a great week, guys.